Hey guys, Joel here with the Shift Brief. Thanks for tuning in again. Today I am joined by another good friend, colleague, flight nurse, critical care nurse, David Hersey. And I'm going to let David go ahead and introduce himself because his resume is a lot longer than mine. So go ahead, David.
Well, yeah, thanks, Joel. This is a great. I've never done this before, so I'm kind of excited.
Yeah.
Been a critical care nurse for about 26 years now, and I probably would say about that 17, 18 years of that has been involved with critical care transport here in Nova Scotia, and as well, like a lot of people up north in the Yukon. And I have a fairly extensive experience with medical, surgical, neuro ICU, and a bit of CCU as well. And my particular interest is pre-hospital mechanical ventilation. So
Yeah. See,
yeah,
that's why I let you introduce
yeah.
yourself because I wouldn't be able to spit that all out for you. So
Oh,
yeah, it's an impressive resume.
thanks, buddy.
The service I work for, David, is our resident vent specialist. Everybody kind of turns to Dave for some education on vents and, just talking oxygenation, ventilation. So to better understand, I guess, CPAP and BiPAP and why we're using them and how to apply them, we should first discuss what oxygenation and ventilation are and how they are different.
Okay.
So what does oxygenation mean?
Perfect. Oxygenation basically means the diffusion of oxygen from a higher concentration in the lungs into across the alveolar capillary membrane into the pulmonary circulation.
Great.
So it's simple diffusion of oxygen. So oxygen, when you think oxygenation, think SpO2 or PaO2 on the blood gas.
Perfect. So you're increasing the PaO2 on the arterial side.
Yes.
And that is what is going to make it readily available for tissues and organ use.
Yes, correct.
What is ventilation?
Ventilation is the elimination of CO2. So when you breathe, CO2 diffuses into your lungs and you exhale it out.
Yeah.
And you blow it off. And for anybody in the pre-hospital, you can see the end-tidal CO2 tracing on your monitor.
Yep.
That's the patient blowing off CO2.
Yeah, so it's a byproduct of cellular metabolism.
Correct.
What CO2 ventilation.
Yeah.
And today's episode of the Shift Brief, we're going to specifically talk about non-invasive ventilation, so CPAP and BiPAP.
Yeah, perfect.
So I guess to start off, Dave, do you want to just talk about what CPAP is? And
yeah, basically CPAP, or continuous positive airway pressure, is essentially PEEP, and it having this move into the pre-hospital environment has been a fantastic development. Like if you look at the research and stuff like that, any service that adopts pre-hospital CPAP sees like a 50 to 60% drop in intubations, which is very significant.
Yeah, it's substantial.
Yeah, and I would say it's even as true for us since we've got the Hamilton and we have much better non-invasive capacity.
Yep.
Like our intubations have dropped by 50%, where we can just give patients, provide the care they need on CPAP and then sometimes BiPAP as well.
Yeah, no, absolutely. It's a wonderful thing. Use obviously CPAP a lot on ground when I was there, and then BiPAP. Certainly love having that tool at my disposal out here.
Yeah. And the one thing I would say with like a ground CPAP device, it's very simple one-use device, and it's considered like a low flow device, meaning that you just have connected to oxygen tubing and have a flow rate between say 5 and 15 liters per minute. Each device will be different. You sort of have to check the specifications on that.
Yep.
And it will generate a PEEP between 5 and 15 centimeters of water.
Yep.
And just the way it's designed is when the oxygen flows through, it indraws room air. So it generates a flow rate of like 40 to 60 liters per minute, which is usually pretty good to meet a patient's inspiratory flow demand.
Mm-hmm.
The advantage, like say a ventilator-based non-invasive system has over that is you can generate much higher flow rates, so the patients won't be sometimes as air hungry. And I think anybody on ground who's used these CPAP masks, they probably had the patient gesturing to the face, like they're not getting enough air and stuff like that as well.
At the end of the day,
like anybody.
So if we, recognizing that the people that are watching this, there's going to be a lot of healthcare people. There's going to be maybe some people that aren't familiar with what non-invasive is. So if we break it right down to the core of what non-invasive means, what does that mean to you or to us?
Basically, non-invasive ventilation is providing positive pressure ventilation to a patient who is awake and spontaneously breathing. And it kind of falls into two broad categories. The first one, which is predominantly seen on ground right now, is CPAP. and it basically provides the patient with PEEP. And what PEEP essentially does is improves lung recruitment, so we have more surface area for oxygenation to occur, and that's how it improves the patient's SAT. It also reduces preload, because when you go from a negative to a positive pressure, it reduces venous return to the heart,
Yeah.
which essentially reduces left ventricular volume, and your heart pumps a little better.
Yeah.
And this is why like there's very solid evidence for CPAP alone for like COPD patients, congestive heart failure patients, very strong evidence in the hospital and outside the hospital. When it comes to pneumonia and influenza, the evidence is a little weaker on that as well. But that said, if you come across one of these patients on ground who is respiratory failure, I would definitely use CPAP. The one category that can be a bit challenging but super rare would be like the status asthmaticus patient
Mm-hmm.
with CPAP. The evidence is a bit weaker on that as well.
Before we dig into that too much, I'm just going to circle back because
Yeah.
David is so friggin' smart
Yeah.
that we throw out those terms there
Yeah.
that are common to us, but I just want to explain a little bit. So when we're talking about PEEP,
Yeah. Good
PEEP,
call.
PEEP stands for positive end expiratory pressure.
Correct.
So that's the pressure that's in the airways at the end of expiration.
Yes.
And by maintaining that pressure from the air in the lungs, it's essentially keeping the balloon inflated.
Yeah.
So it's keeping the alveoli open.
Because of the PEEP that's being applied to the lungs, sometimes you may see a decrease in the patient's blood pressure.
Yeah.
And also in higher levels of PEEP, it can cause like gastric distension, like filling of the stomach, and potential risk of aspiration as well. But those are fairly manageable risks when the benefit from oxygenation is much higher.
Yeah. So we, David and I, in the service that we work for, we have the luxury of working with the Hamilton T1 ventilator. Hamilton, if you want to sponsor this this
great,
podcast,
and
feel free to reach on out.
Yeah.
But yeah, we have the benefit of the T1, which is very user friendly.
Yeah.
I know for paramedics coming with no vent background and entering critical care, it's a pretty steep learning curve. But the Hamilton T1 certainly it makes it easier. It's so user friendly. So for the rest of the episode, I think we'll just talk about the Hamilton and those two modes and kind of how it applies to us and how we apply it to a patient. So, and we'll start with CPAP because we've already kind of touched on that. So in the non-invasive mode, how would we set up CPAP on a T1?
Perfect. So when you identify a patient that has basically it's an oxygenation problem, like mentioned, from like COPD, congestive heart failure, pneumonia, influenza, the key thing is you can apply like supplemental oxygen, like nasal cannulas, to the patient while the vent's getting ready, because unfortunately it just takes a bit of time, and build a rapport with the patient while your partner gets the vent ready.
It's pretty uncomfortable.
It's pretty uncomfortable, yeah. And then while that's going on, the partner you'll enter the non-invasive mode in the ventilator and set a level of CPAP or PEEP. And generally the theory behind this is you start low and build your way up, because the key for successful non-invasive ventilation is buy-in from the patient. Like if you feel the patient needs 10 a PEEP, 12 a PEEP, or 15 a PEEP, and you come at them like high levels of PEEP right out of the gate, it's problematic. So you have supplemental oxygen on, you program the vent, you set your level of PEEP, and you set your level of FiO2. And again, the advantage of the vent over like the ground CPAP device is we can tailor the FiO2 anywhere from 21% to 100%, depending on what we want. And two, believe it or not, the vent actually consumes a lot less oxygen than the ground CPAP device, which will drain a tank in like 5-10 minutes or something.
It's fast.
It's fast. Whereas a normal decylinder will last a significant amount of time with the T1. Once the T1's ready, the key is explaining the procedure to the patient, because unlike, say, an RSI situation or intubated patient who's sedated, you need to have their buy-in. And if they're cooperative, which is ideal, but not always the case, you can sometimes even have them hold the mask, turn the vent on, the CPAP will be blowing in their face, and just have them hold it up to their face for a second and say, just breathe with me, and just try to coach the breathing pattern. And once they get comfortable with that, then you pull the straps on to secure the mask to the face, and then make sure you try to minimize the leak. The Hamilton measures a leak percentage. It tells you how much the leak is, but ideally you can just feel around the mask and make sure it's not like a lot of air is blowing out of the side. Now, the key is like there's always going to be a degree of leak with a non-invasive mask. You just do not want to squish it on their face too tight.
Right.
It gets to be quite uncomfortable.
Right. Yeah. And when CPAP starts to work, you see it on these patients almost immediately.
Yeah.
They might not like it at first, but when it actually starts working, you can actually see that look of relief kind of
Yes.
wash over them. And
Yes.
it's hard to communicate with these folks with these masks on. They're loud,
Yeah.
their voice is muffled. So I like to use the thumbs up, thumbs down
Yeah.
with them. That's the best way to get information to them, or have them write down on something, but you're not going to be able to have a conversation with them.
No, absolutely not.
Once the mask is on.
Yeah.
So at rest, without CPAP applied, do we have PEEP now inside of our lungs?
Well, there's what's like at rest, just breathing spontaneous. We usually have about 5 centimeters of water of PEEP. So some people say that's
Right.
this natural level of PEEP. So like you can start on CPAP by applying this continuous level of PEEP. It will slowly start recruiting in the lungs, and application of PEEP is not an immediate thing. It usually takes for a reasonably healthy person, probably a good 10-15 minutes for recruitment to occur.
Right.
For people with, like, say, really wet congestive lungs from CHF, it might take a bit longer. So you got to be patient with it. But like you said, Joel, you tend to see that dyspnea go away, that air hunger fades away. They start getting a little more comfortable. And this is also at the stage of things where you got to be careful about considering hypotension, because, if you basically feel like you're dying, and feeling is a very stressful experience, obviously, and these patients who tend to be very tachy, hypertensive, they have low sats, they're anxious. And when you get them on a CPAP, they relax a little bit.
Mm-hmm.
And say they've been unwell for a couple of days at home, it's not uncommon to see the blood pressure drop fairly significantly,
Right.
or their heart rate to come down. And you have to ask yourself, is that change in hemodynamics due to them being volume depleted, and the sympathetic stress response has been reduced because they're comfortable
Right.
on non-invasive, or is it too much PEEP? And I would say almost always for these sick respiratory patients, it's the first case that maybe a little bit of fluid, start a bit of norepinephrine if you have to.
Yep.
But like discontinuing non-invasive, especially if you only get like 5 of PEEP,
Yep.
is probably not the answer.
Yeah, and give it a chance is essentially what you're saying.
Give it a chance. Yeah.
We all do it in PEA cardiac arrest. We talk about reversible causes.
Yes.
Apply it here too. Like,
Yeah.
some clinical reasoning is
Yes.
is pretty important.
Yeah.
Because like you say, if it's working, why pull it off?
Yeah.
Just make sure that the hypotension is related to
Like
something
now,
else.
exactly. If someone's
So-
on like home CPAP for sleep apnea and stuff like that, you can ask them what the settings are, which is pretty rare to have that much information.
Yep.
Generally, if someone's got like a normal body habitus, like 5, if they're particularly a little bit on the obese side, you can start with 8.
Yep.
And then, like, again, you start low, explain the procedure to the patient, coach them through it, get them to hold the mask, bring it up to the face, kind of coach the breathing. And when they get the rhythm down, you pull the strap over, communicate thumbs up, thumbs down.
Yep.
And then you should watch that respiratory rate should come down.
Yeah.
And that sat should slowly come up. And then after like a bit of time, because again, like I probably wasn't clear enough at the beginning, but CPAP is essentially used for an oxygenation problem. It's going to fix your SpO2 and your PaO2 for blood gas.
Right.
It's really not going to help that much for a ventilation problem. It will help reduce some of the work of breathing, but if the patient is looking like they're having respiratory muscle fatigue and they have increased work of breathing, and this is where we would bring on BiPAP. BiPAP, like the name suggests, Bi is 2 pressures. So in addition to continuous positive airway pressure, which lasts through both the inspiratory and expiratory phase, it's continuous, like the name suggests. With BiPAP, you also offer IPAP, which is inspiratory positive airway pressure.
Exactly. Yeah.
Or like it's also called pressure support. Unfortunately, the terminology is different from different manufacturers and stuff like that, so it gets really confusing.
There's actually an app created to help interpret vent lingo.
Yes.
Because there is so much different terminology that's
Yes.
specific to whatever device that you're
Yeah.
using. Just to recap
And like
on
speaking
it,
of app,
CPAP is applied for patients that need correction in oxygenation.
correct.
It's not ventilation.
Yes.
So COPDers, not really those asthmatic
No.
patients.
No.
We can use it in carbon monoxide patients. You and I
Yes.
had a discussion about
Yeah,
that earlier.
exactly.
So just about flooding the system with
Yeah.
oxygen, because
Yeah.
their SpO2 sucks, their PaO2 sucks. It's loud.
Yeah.
It's uncomfortable at first, but with some good coaching, we can get patients
Yeah.
through it, and they'll find it quite beneficial.
Yeah.
The disposable ones use entrained air, similar to like a Venturi mask. It's
Exactly.
going to pull air in and train with that oxygen that you're giving at 15 liters or a flush rate to adjust to whatever CPAP level you want to achieve. And that's how that oxygen is delivered. The patient has their own intrinsic respiratory rate and effort, and it doesn't do anything to actually provide pressure support to push air into the lungs. It just provides pressure for them to breathe against to keep the bubble inflated.
Exactly.
Is that a good summary of CPAP?
And I think you mentioned like it increases like the other map we don't talk about is mean airway pressure, because like when you say put nasal cannulas or face mask on someone and turn up the flow rate, you're just trying to create a higher gradient of higher concentration of oxygen in the lungs that diffuses across the alveoli, capillary membrane into the blood. Now, if you put an oxygen mask on somebody, nasal cannulas, and you keep turning it up and the SATs don't come up, then you have a shunt problem. Then you put CPAP on, recruit the lungs, you got more surface area for diffusion and a higher mean airway pressure, which also helps enhance diffusion. And then if that is, say your SATs are coming up, but the patient has increased worker breathing, like you mentioned the example, the patient's breathing 38 times a minute. Say there's, and the SATs are 80 something. Say the SATs come up to 92%, and you're happy with that because they're a COPD patient, but their worker breathing looks kind of labored, and you're worried about them fatiguing. Then you can just increase the pressure support or IPAP, and it's the same.
And that's on BiPAP that we're talking about now.
Yeah, exactly.
And so now that we understand what CPAP is, let's talk about BiPAP for a minute. And CPAP is a good starting point because it's one of the settings. So the CPAP is EPAP. The two terms are used interchangeably. And when we add in the other pressure, so the IPAP or the pressure support component of BiPAP, that is what allows you to improve ventilation in addition to the oxygenation that's occurring from the CPAP. So it's kind of like taking that oxygenation and just adding another tool to improve ventilation for that patient. So how does that work?
Basically, the ventilator, it's triggering is the ability of the ventilator to detect inspiratory effort from the patient. So if you're in a BiPAP mode, the vent's monitoring for a change in flow within the circuit. So when you inhale and your thorax expands, your diaphragm drops, it's going to create a pressure drop, and the ventilator detects that, and it understands that means you're trying to take a breath, and then it will turn on your inspiratory valve and deliver the additional pressure support to you at whatever level we set it as, and it will just help you generate a larger tidal volume in, and then you're going to inhale, blow off a larger tidal volume, and in turn blow off CO2. So if you had a arterial blood gas or venous blood gas, you would see the CO2 levels on the gas drop. If you have like end-tidal nasal cannulas, you would probably see the CO2 drop as well. Or if you connect an end-tidal CO2 monitor within the circuit for your BiPAP, you'll see an end-tidal CO2 drop. That's a measurement, but clinically what you should see is the patient's work of breathing diminishing.
Right. Because it's supplying that extra pressure support on top, so they don't have to work as hard to get a full breath in. Because the vent is doing some of that work.
And that's the limiting factor with like why all BiPAP has to be ventilator based, because you need to set the trigger sensitivity and you need to set the cycling sensitivity as well, so that the ventilator can correctly determine when the patient wants to breathe in and when the patient wants to breathe out. And you can see the problem with if you try to switch from a CPAP mode to a BiPAP mode and you get that trigger and cycle wrong, when a patient may want to breathe in, the vent won't answer them. Or if the vent answers them and they're ready to breathe out, it might continue on delivering the breath, or it might make the breath too short for them. And then they start to panic and become very anxious and stuff like that as well. So this is one of the reasons why you need a ventilator like the Hamilton T1 for that. Like whereas when I started, we used like an Oxylog 1000, we used like an LTV 1000, LTV 1200. Vents like that were not capable of delivering CPAP or BiPAP. And in fact, we just used pretty much the same masks grounded up until now we get the T1. It's much better.
Yeah. No, it's great. I've used it on a wide variety of patients, and when it works wonders. And we avoid intubation in a lot of these patients because of BiPAP. It's reducing their work, their fatigue. It improves their
Yeah.
oxygenation, specifically improves their ventilation. So for sure. We also have the luxury of having non-invasive, so BiPAP spontaneously timed,
Yes.
which is or non-invasive spontaneously timed.
Yeah.
So using BiPAP in that manner, there's a bit of a move to utilize that for pre-oxygenation
Yeah.
for patients that you're going to perform an RSI
Yeah.
on, so rapid sequence intubation.
Yes.
And the benefit of that is it essentially acts as a BVM
Yes.
that you're hands free. So you're getting that inspiratory pressure, you're getting the CPAP,
Yeah.
you're getting a tight mask seal that's secured by the band on their head. And you're getting that spontaneously timed backup rate.
Correct.
So you can set it to 10, 12,
Yeah.
16, whatever you want it to be. And if the patient becomes apneic as a result of whatever their lung disease is or their patho that's brought you there,
Yeah.
the vent is still going to pre-oxygenate. So if we were to talk about CPAP versus BiPAP, what patients would you apply CPAP to versus BiPAP?
Perfect. I would say like these, like we've mentioned a few times, the COPD patient, the CHF patient, the pneumonia patient, and influenza patients with low SATs, but reasonable respiratory muscle effort can go on CPAP. The same patient population, but with respiratory muscle fatigue, like increased work of breathing, can go on BiPAP just to improve the ventilation and rest the respiratory musals.
That's a great way of looking at it.
Yeah.
It's almost just like an escalation of
Yeah.
care.
If they have maybe to the point where they have an oxidation problem, like a low SpO2, obviously, and a ventilation problem, so like an end-tidal CO2 that's quite high, and maybe some central nervous system dysfunction, they're having apneic periods and they're not breathing that effectively, or they're quite weak, then I would use non-invasive ST and just have a little backup rate in the background. And just tailor the rate depending on the clinical
episode
situation.
Today. A colleague of yours showed us to cover non-invasive ventilation and the agitated patient, plus or minus sedation and how that goes. And like you're alluding to, it's very tricky. So a lot of providers will say CPAP is contraindicated in patients with altered level of consciousness. But often our patients that require CPAP have altered levels of consciousness. So we need to consider hypoxia or hypercapnia as one of the reasons.
And what's the alternative? Like two sources of oxygen, like not nasal cannulas and face mask. If you feel like because they're slightly altered, you can't use non-invasive, or old school, put a BVM over their face and try to assist the respirations and see how that goes. Like if they're combative and agitated, putting a BVM over their face is not going to help.
I think the biggest concern is the risk of aspiration. If they suddenly vomit inside that mask, you get that extra pressure, especially from BiPAP, that's going to push them down into their lungs, and they're going to have an aspiration pneumonia, which obviously is a real, it's a valid concern. But we're going to do our due diligence, maybe even consider prophylactically treating with an antiemetic when you're giving BiPAP or CPAP. So those agitated patients, I would say.
And to that point too, sorry,
no, it's okay. Go ahead.
Is like the general. It's in all the textbooks. I'm not really sure how they came up with this number, but they generally say if you're in CPAP, if your PEEP is not greater than 15, the chances open the gastric sphincter is pretty low, so the chances of gastric distension is low.
Okay.
And then in BiPAP, if your total pressure is less than 15, obviously the chance is less as well. So that's another reason why it's like go low and walk your way up, whether it's CPAP or BiPAP, and find the way to achieve your oxygenation ventilation goals with the lowest possible settings. And there's also emerging evidence, and this is one of the reasons, like I think it's a mixed bag on pneumonias and influenza patients is patients can get ventilator and lung injuries from non-invasive with high pressures for long periods of time as well.
Yeah, absolutely. When it comes to the sedation part of having patients be compliant with CPAP or BiPAP, whichever form you're using, your agency that you work for is going to have pretty well-defined protocols around that. So I would always defer back to whatever your protocols or your CPGs are saying. If they're not well-defined, you should have access to an online medical physician. You can have a conversation with them. Certainly used it, seen it used, benzodiazepines, maybe if they're experiencing pain, you can talk
Yeah.
about fentanyl, things like that,
Exactly.
and just super low doses. Because
Yeah.
once you decide to intervene on that patient's airway, whether it's non-invasive or right up through intubation, RSI, etc., you own that patient's airway and you are responsible
Absolutely.
for it. So every decision you make from that point on has to be calculated.
Yeah.
So if you're going to give them some kind of a sedative, hypnotic, or analgesia
Yep.
to make them more compliant with CPAP
Yep.
or BiPAP, do that judiciously and just
Yep.
know that you're responsible for paying attention to that airway.
Absolutely. Absolutely.
Yeah.
And like, if you have like a ground system based low flow CPAP device, again, you can double up. You can put nasal cannulas on the patient and
Yeah.
a CPAP device, and give them more flow. That might help with the oxygenation and decrease the air hunger as well. And also, too, like if the patient needs to take the mask off for a second because they're getting, like, if they're responding well and they just need a little break and the mask is uncomfortable, and you can just take the mask off for a second, and then you have the nasal cannulas here. Just give them some oxygen,
Mm-hmm.
give them a little break, talk to them a bit, maybe put the mask back on, things like that. On patients who are doing well, obviously, if that patient isn't precarious, you don't want to be taking that mask off because you're going to
Yeah.
de-recruit.
Absolutely. And
And
the other patients, like certainly seeing more of them recently for whatever reason, I'm not sure, but CO2 narcosis patients.
yes,
So hypercapnia, their CO2 is super high, and it gives them a presentation like they're intoxicated.
yes,
So they're not making any sense. They're altered, combative,
yes,
sometimes very aggressive, and you're trying to apply some kind of a toxidrome to what's
yeah,
going on and figure out what's going on. Are they diabetic? Have they been
yeah,
intoxicated? Are they post-ictal from a seizure?
yeah,
And all the time their CO2 is
yeah,
120, and
yeah.
it's a ventilation
Yeah,
issue.
and the running joke is the eventually CO2 is the greatest anesthetic there ever was, because the patient will go through the surly, angry stage, combative stage,
Yeah.
again, which is a huge challenge to have them comply with the CPAP,
Yep.
and then it'll eventually become unresponsive, and the breathing rate will just drop right off, and this would be maybe the patient that, if the non-invasive ST mode would be good, because you could put a little backup rate just to help blow that CO2 off,
Right.
and then they'll slowly wake back up. And then it's almost like reverse coaching those hypercapnic patients.
Yep.
Like if they're agitated and then they go into maybe unresponsive because the CO2 is so high. As you blow that CO2 off, they're going to start waking up, and they tend to wake up a bit on the confused, agitated side. Just be ready for it.
Yeah. 100%.
You know?
Well, that's a pretty comprehensive
Yeah,
review of CPAP and
yeah,
BiPAP.
yeah.
Anything else you would add in there in closing?
No, I just think, like, I think things that, like, are mostly designed and planned for the hospital, and then a lot of times EMS looks at it and realizes it's a good idea. And I do feel um, like BiPAP will be eventually probably the standard of care
Mm-hmm.
for most ambulances in a few years. And even medications that are better for agitation, like dexmedetomidine and Precedex, we use that a lot in the hospital too, because it's a clonidine-like medication that helps relax the patient, that doesn't
Mm-hmm.
inhibit like respiratory drive or gives them delirium or any of the complications. So sometimes we'll just put people on Precedex for a little bit while they're agitated and get them on the non-invasive. And then once they get with it, and their oxygenation improves and the ventilation improves, then we can just wean off the Precedex. Just
Yeah.
something to get them um, to uh, not comply is a bad word, but be cooperative with the therapy,
Right.
so that we don't have to go down the more invasive road of intubation and stuff like that.
Absolutely.
I mean, in fact, like now with non-invasive, like in most medical ICUs, I can't recall the last time I saw an intubated COPD patient show up, because they're all basically fixed with non-invasive now.
Yeah.
Back when I started, we used to have like fairly frequent admissions of COPD patients who were intubated.
Yeah.
Now who just
And intubated for a long time.
long time. Yes, because you get them on the vent, it's hard to get them off the vent. Now they all come into the emerge. They have like the COPD pathway, boom, or pre-hospitally. You start them on CPAP,
Yep.
and they just carry on within the hospital.
Absolutely. Well, David, thanks for
Yeah.
taking the time to do this. Guys, this
No
is
problem.
David Hersey.
Yeah.
As I said, our vent guru, our oxygenation specialist, and he's actually almost completely
Yeah.
done writing a textbook a textbook,
I
guys,
know.
on ventilation and oxygenation. He's working on a title today. I'm interested to see what he comes up
Yeah,
with.
I have my titles are very boring. I need something with a little more like a little excitement to it. But like, yeah, once I finally get the editing done, I'll be farming the chapters out to all my colleagues to suffer through and do editing
Yeah,
for
well, I
me.
mean, I'm looking forward to it. But if you guys have the opportunity and you're have an interest in it,
Yeah,
you see David's
yeah.
textbook out there, pick up a copy, check it out, say hi to him, and yeah,
Oh my God, now I'm under
support it.
pressure to actually finish the editing and get it done.
Yeah, you have to
Yeah,
finish it, David. You're
and
obligated now.
it'll be like, meanwhile, 2028, I'm done.
Yeah,
Actually, that's
exactly.
probably what's going to be more accurate.
Well, guys, thanks for tuning in. Make
Yeah,
sure that you subscribe to the Shift Brief on YouTube. Follow me on the socials.
yeah.
We're gonna get David on the socials here soon, but yeah,
I'm
subscribe
on
on
no
YouTube.
socials,
You're on
though.
none, yeah,
None,
none.
none.
Takes him a week to answer a text, so
I
we're
know.
lucky we have him here today. All right, guys,
I
thanks
think it
again.
times. Hey, thank you. Thanks, Joel. It was fun.